acute ascending polyneuropathy, Julian Baris Landry syndrome. The syndrome, which affects both sexes at any age, peaking at 20 to 50, is found worldwide and in all seasons. Its cause is unknown, though current authorities consider it to be due to hypersensitivity or allergy to unknown viruses or allergens. In around 50% of cases, the onset of symptoms is preceded by a mild gastrointestinal or respiratory infection. Clinically, the syndrome presents as a symmetrical weakness of muscle. There is some wasting, hypotonia, and a partial or complete loss of associated deep tendon reflexes. The motor symptoms start distally and move proximally, with lower limb involvement preceding that of upper limb. The disease may progress to involve the trunk and cranial muscles. Pain is a variable symptom, though there is usually tenderness on deep pressure, especially to motor points in muscle and nerve trunks. Paresthesia is often described in the limbs. Both sensory and motor nerve conduction velocities are reduced. Autonomic functions are sometimes affected, usually cardiac muscle, which may lead to sinus arrhythmias and variable blood pressure. Visual impairment is rare, though papilloedema is occasionally seen. The hearing is not usually affected and cerebral symptoms are rare. The symptoms may progress for one or several weeks until the disease peaks and plateaus out, gradually regressing symptoms in a reverse order of onset. Pathology. The disease process affects the spinal roots and nerve processes, primarily involving the Schwann cells, and this results in segmental demyelination of the nerve process initially. Later, there is proliferation of Schwann cells. The axon remains intact, though demyelinated, and can conduct an impulse with a much reduced velocity. There is an associated perivascular lymphocytic inflammatory exudate of the peripheral nervous system, and the other organs, such as the heart, lungs, or kidney, may show this. Recovery takes place by remyelination of peripheral axons, though the myelin sheath is thinner and internodal distance is less, but eventually the conduction velocity returns to within normal limits. Prognosis. In epidemics, the mortality is high, but usually in a single incidence of this syndrome, most patients recover completely. The more favorable ones in 3 to 6 months, although more often times scale is 1 to 2 years. Complications. In severe cases who need respiratory assistance, infections of the lower respiratory tract can be a hazard. Deep vein thrombosis due to paralysis affecting the limbs and thereby removing the muscle pump effect, and the temporary loss of an effective respiratory system can also occur. The retention of urine is an uncommon complication. Cardiac arrhythmia and labile blood pressure have already been mentioned as a possible complication. Treatment. If respiratory assistance is required for the Guillain-Barré Landry potential patient, ideally it should be managed in an intensive care unit as the chance of life expectancy is enhanced under these conditions. The normal nursing care for fluid intake, skin, and pressure area care is needed. Sometimes ACTH is prescribed for these patients to reduce the inflammatory response, but clinically results vary. Physiotherapy management under intensive care in the acute progressive stage. During this period of treatment, when the patient is to all intents and purposes tetraplegic with respiratory distress, the aims of treatment are to maintain a clear airway, prevent lung infection, maintain anatomical joint range, support joints in a functional position to minimize damage or deformity, assist in the prevention of pressure sores, maintain peripheral circulation, provide psychological support for the patient and relatives. Methods: maintenance of a clear airway, prevention of lung infection. The patient's breathing will be assisted by intermittent positive pressure ventilation via a cuffed tracheostomy tube. This leads to some limitation of the positions in which the patient may be placed to posteriorly drain areas of lung tissue. Some compromise is necessary, and in the absence of lung infection, 2-hourly turning into supine or side-lying positions will aid the removal of secretions from all parts of the lung. A suction catheter is used to remove secretions from the respiratory passages until the cough reflex reappears. Manual techniques used to assist in maintaining and clearing the airway include vibration with or without overpressure. To enhance expansion, a 2 to 4 liter anesthetic bag can be used for patients with tracheostomy tubes, although care is needed for as a reduction in cardiac output can occur as a result of bagging. 2 people are necessary for this technique, one to squeeze the bag and the other to apply chest manipulations. To stimulate a cuff, rib springing techniques are useful, although a faulty technique may reproduce fractures of the ribs. As chest care is relatively long term for these patients, a 2.5 cm thick piece of foam rubber placed under the physiotherapist's hands makes rib springing more tolerable for the patient. Once the patient is weaned off the ventilator, respiratory care is a shared responsibility between patient and physiotherapist, and adequate expansion in all areas of the lung and effective cuffing must be taught to the patient. As neurons recover their function and muscle once again responds to a nerve impulse, active exercises to those muscles may commence. Patients at this stage tire fairly quickly and there are still some aches and pains in the limbs. To maintain normal joint movement, gentle passive movements should be given through full range at least 3 times a day. Multi-joint muscle groups should also be placed on full normal stretch. Patients appreciate these simple procedures as they comment later on a feeling of tension cramp building up in the limbs, and this sensation is relieved by passive movements. The hip joint must be fully extended at least daily when the patient is in the lateral position. The shoulder joint range also should be maintained, care being taken that movements occur at the glenohumeral joint and not just the shoulder girdle. The temporomandibular joint should not be forgotten. Ankle, ankles, wrists, hands, and feet also need accurate passive movements applied, as these areas will be the last to recover. Serious loss of joint and muscle extensibility with functional loss and unacceptable cosmetic appearance could be due to sloppy passive movements. Support of joints. Light splintage using plastazote is required to support the peripheral joints in a comfortable and functional position during the time of flaccid paralysis. Splintage will prevent abnormal movements and untoward damage occurring to the joints. Bed cradles should be used to avoid pressure on the joints from bedclothes. The general position of the patient in bed will alternate between supine and side-lying positions. Sandbags and pillows must be used to stabilize these positions, and if splints are used, a careful check should be made to avoid damage to other parts of the body from pressure or rubbing by the splint. Prevention of pressure sores. The physiotherapist joins the nurse in having a responsibility towards frequent checking of the patient's pressure areas. The patient is normally on a 2-hourly turning regime to prevent chest complications and pressure sores. As a physiotherapist usually times her visit to coincide with these turns, she can check the new and old pressure areas. Should a pressure sore develop, the physiotherapist may require to give ultraviolet radiation or ice cube massage to the sore area to enhance healing process. Maintenance of circulation. The passive movements described in 3 will assist in increasing venous return. Additionally, gently by firm effleurage massage may be given to the lower limbs, although by some method of communication, the patient should indicate if this procedures produces extreme discomfort. Psychological support. The patient with this syndrome has unimpaired cerebral functions, therefore his perception is unclouded. As treatment is commenced, the patient should be involved in his treatment. He must be told what is to be done to him very simply and undramatically. Include the patient in conversation if another member of staff is present. Never discuss the prognosis or condition with the colleague within earshot. The patient's relatives should be briefed on the points above and must be reassured that the prognosis, though slow, is excellent so that visiting time is a supportive experience rather than a frustrating and upsetting time for the patient. Recovery stage: when the patient can maintain his own airway and ventilation and some motor recovery is occurring, an assessment of the patient's problems is required to define treatment priorities. The assessment should be detailed under the following headings: respiratory system, rate, depth, and pattern of breathing should be noted, vital capacity and chest expansion recorded, joint range on active and passive movement also noted should be joints which still require splint support, motor power of the recovered and recovering muscles, sensation, all cutaneous modalities including vibration and two-point discrimination, proprioception, balance in various functional positions together with details of methods of support needed to stabilize a position, independence of self-care, motivation and general psychological approach to life in general. Physiotherapy: as patients recover at different rates, it is impossible to outline a course of treatment to suit them all. However, certain basic principles should be common to all treatment programs, and these are defined below. Some or all of the principles listed are applicable in an ongoing scheme of treatment. In general, during recovery of nerve function, motor improvement occurs more rapidly than sensory, and treatment plans should take this into account. Principles of physiotherapy: maintenance of the airway and ventilatory capacity. Care of respiratory function is an aim for some time during the recovery phase. Patients can be taught breathing techniques and adequate coughing together with instruction on frequency of practice, that is 3 to 4 times a day, say prior to each meal. Maintain and improve joint range. The more peripheral joints will require splintage and passive movements for some considerable time. The patient's relative can be taught care and application of splints and effective and safe passive techniques of movement. The patient will now be allowed out of bed and in sitting should sit squarely on the buttocks with shoulders level. Strengthen and re-educate normal muscle function. The proximal muscles recover first, and to facilitate voluntary contraction of muscles, some of the following techniques may be used: neuromuscular facilitation techniques, afferent stimulation of skin, free active exercises, equilibrium and writing reactions, progressive resistance exercise, hydrotherapy, suspension, springs, pulleys, simple progressive to more difficult circuits of power and endurance. The patient should have a program of core exercises which he must practice for a certain number of repetitions, which are increased daily and frequency throughout the day. Re-education of sensory awareness, cutaneous stimulation, the use of different materials, textures, shapes, and weights will assist in perceptual re-education. Proprioceptive, the use of equilibrium and balance responses, use of alternative systems, that is vision. To protect the integrity of the skin, the patient or his relative must be made aware of the importance of skin care, both of hygiene and protection, especially the hands, against thermal or mechanical damage. Restoration of normal function, lower limbs, various gait aids and orthosis may be required initially to restore a safe walking pattern appropriate to the weakness, incoordination and proprioceptive loss. Upper limbs, some splintage is often necessary and certain aids to daily living are required to enable the patient to be independent in his personal care, that is hygiene, toilet, feeding and dressing. Restoration of maximal independence. In some cases, recovery may not be complete and the patient's environment must be restructured to accommodate his disability and his needs. Motivation. Most patients in the acute stage will not believe that they will recover. It is sometimes, but not always, useful for the patient to see a person who has recovered well from the same illness. The physiotherapist must help the patient and often relatives to gain the will to join in the treatment and so regain a productive and happy life again.